Welcome to this Step 2 clinical knowledge review on cardiovascular prevention test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam for cardiovascular prevention and teach you strategies to pick the right answer quickly and confidently. Remember, the goal here is not to re-teach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the cardiology and preventive medicine sections of first aid and your question bank before or alongside this video. Here is what we are going to cover today. First, we will learn how to recognize high-yield question stems related to lipid screening, hypertension management, and aspirin for prevention. Second, we will apply specific strategies for cardiovascular risk assessment questions and statin initiation decisions. And third, we will master the next best step question format for cardiovascular risk reduction. This video assumes you have some baseline knowledge from your review resources. We are here to sharpen your test-taking approach. Our first strategy is the statin decision framework. When you see a question about lipid management, immediately ask yourself, is this primary prevention or secondary prevention? For primary prevention, the key factors are patient age between 40 and 75, a low-density lipoprotein cholesterol above 70, and the 10-year atherosclerotic cardiovascular disease risk score. If the risk is above 20%, the answer is high-intensity statin. If the risk is between 7.5 and 20%, you need a risk discussion with the patient. For secondary prevention, the patient already has established cardiovascular disease, like a prior heart attack or stroke, and they automatically get a high-intensity statin regardless of cholesterol numbers. No risk calculator needed. Make this your first mental framework for lipid questions. Strategy 2 is all about hypertension screening thresholds, because the boards test this in many different ways. First, remember that hypertension must be confirmed on 2 or more separate visits. If a question gives you just one elevated reading, the answer is usually to repeat the measurement, not to jump to medications. Know the blood pressure stages. Elevated is between 120 and 129 systolic. Stage 1 is 130 to 139 over 80 to 89, and stage 2 is 140 or higher over 90 or higher. For stage 1 hypertension, you start with lifestyle modifications and add medication only if the 10-year cardiovascular risk is above 10%. For stage 2, you start pharmacotherapy immediately. Know the first-line agents: thiazide diuretics, calcium channel blockers, angiotensin-converting enzyme inhibitors, and angiotensin receptor blockers. Pay special attention to special populations. Angiotensin-converting enzyme inhibitors are preferred for diabetic patients with proteinuria, but are contraindicated in pregnancy. Now let us go through high-yield stem recognition. For statin initiation, the classic stem is a middle-aged patient with risk factors like diabetes, smoking, or family history. They will give you either the 10-year risk score or enough information to determine risk category. When the score is above 20%, always choose high-intensity statin. When it is between 7.5 and 20%, look for the shared decision-making answer. For hypertension management, look for a patient with persistently elevated blood pressure confirmed on multiple visits. The key is knowing the treatment thresholds and matching the right first-line drug to special populations. For aspirin in primary prevention, the classic stem is a patient between 40 and 59 with elevated cardiovascular risk. Remember that current guidelines emphasize individualized decision-making based on bleeding risk, and the boards no longer support blanket aspirin recommendations for primary prevention. These stems repeat over and over on practice questions and on the real exam. Let us work through our first practice question. A 55-year-old man with type 2 diabetes and a smoking history presents for a routine visit. His low-density lipoprotein cholesterol is 145 milligrams per deciliter. His 10-year atherosclerotic cardiovascular disease risk score is 22%. He has no history of heart attack or stroke. What is the most appropriate next step in management? Take a moment to think about this before we walk through the answer on the next slide. Let us break this down step by step. Step 1. Spot the pattern. This is a 55-year-old male with diabetes and smoking, a low-density lipoprotein of 145, and a 10-year risk score of 22%. These risk factors place him firmly in the high-risk primary prevention category. Step 2. Apply the rule. When the 10-year atherosclerotic cardiovascular disease risk score is above 20%, the patient needs high-intensity statin therapy. This is the guideline recommended threshold. Step 3. Eliminate wrong answers. Lifestyle modifications alone are insufficient when risk is this high. Moderate intensity statin is too conservative for a score above 20%. Repeating the lipid panel just delays necessary treatment. The correct answer is C, high-intensity statin therapy. Here is our second practice question. A 48-year-old woman presents for a routine visit. Her blood pressure today is 142/94, and a repeat reading 15 minutes later is 138/92. She has no prior history of elevated blood pressure and takes no medications. She has no diabetes or kidney disease. What is the most appropriate next step? Think through this one carefully. The key here is whether this is enough to diagnose and treat hypertension. We will walk through the answer next. Let us work through this answer. First, read the question carefully. This patient has elevated blood pressure readings from a single visit. The classic board trap here is jumping straight to medication. Guidelines require confirmation on a separate visit before diagnosing hypertension and starting treatment. The exception is severely elevated blood pressure, typically above 180/120, which would require immediate treatment. Now, why does repeat measurement win? Because rechecking on a separate visit confirms the diagnosis and rules out white coat hypertension. Starting a thiazide or an angiotensin-converting enzyme inhibitor today is premature without a confirmed diagnosis. Ordering a renal ultrasound is only appropriate if you suspect secondary causes of hypertension, which nothing in this question suggests. The correct answer is C, recheck blood pressure at a follow-up visit in 1 month. Let us review Aspirin for cardiovascular prevention, because the guidelines have shifted and the boards are testing this heavily. For primary prevention, low-dose aspirin may be considered for adults aged 40 to 59 years, with a 10-year cardiovascular risk of 20% or higher, but only when the bleeding risk is not increased. This is a shared decision-making conversation. The key change is that aspirin is no longer recommended for routine primary prevention in adults over 60 because the bleeding risk outweighs the benefit. For secondary prevention, the rules are different. After a myocardial infarction, acute coronary syndrome, or coronary stent placement, aspirin is always indicated unless the patient has a true allergy. Dual antiplatelet therapy with aspirin and a P2Y12 inhibitor like clopidogrel or ticagrelor is the standard of care after stent placement. The boards love testing whether you can distinguish between primary and secondary prevention aspirin indications, so make sure you know this distinction cold. Here is our third practice question. A 65-year-old man with well-controlled type 2 diabetes and no prior cardiovascular events asks about starting daily aspirin to prevent a heart attack. His 10-year risk score is 18%. What is the most appropriate recommendation? This is a classic primary prevention question where you need to weigh the benefits of aspirin against the bleeding risk based on the patient's age. We will walk through it next. Let us break down this answer. The classic pattern here is a patient aged 60 or older with no prior cardiovascular events asking about starting aspirin. Current guidelines recommend against initiating aspirin for primary prevention in adults 60 and older because the bleeding risk outweighs the cardiovascular benefit. Now, the key distinction: starting low-dose aspirin is wrong because this patient is over 60. Full-dose aspirin carries even more bleeding risk. Adding a proton pump inhibitor to reduce gastrointestinal bleeding does not change the fundamental risk-benefit calculation at this age. Even though his 10-year cardiovascular risk is elevated at 18%, his age places him in the group where primary prevention aspirin is not recommended. The correct answer is C, do not start aspirin for primary prevention. Here is a critical test-taking pearl about cardiovascular risk calculators. The pooled cohort equations are used to estimate 10-year atherosclerotic cardiovascular disease risk. The inputs include age, sex, race, total cholesterol, high-density lipoprotein cholesterol, systolic blood pressure, whether the patient is on blood pressure treatment, diabetes status, and smoking status. You do not need to calculate this on the exam, but you absolutely need to know how to use the result. Risk categories are: less than 5% is low, 5 to 7.5 is borderline, 7.5 to 20 is intermediate, and above 20 is high. A risk above 20% means high-intensity statin. Between 7.5 and 20% means consider moderate-intensity statin with a risk discussion. Know that risk-enhancing factors like family history, metabolic syndrome, chronic kidney disease, or elevated high-sensitivity C-reactive protein can push a borderline patient toward treatment. Also know that a coronary artery calcium score of 0 can defer statin therapy in patients who are on the fence. These are high-yield details. That wraps up our review of cardiovascular prevention test-taking strategies for Step 2 clinical knowledge. Remember to review the cardiology and preventive medicine chapters in first aid in your question bank. Focus on the lipid management guidelines, hypertension treatment thresholds, aspirin recommendations, and cardiovascular risk assessment tools we covered today. Visit www.roadmap2residency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.